Hi, my name is Pete Sloan, and I'm a pulmonary and critical care physician practicing out of Baltimore, Maryland. I'd like to continue on to the second of a three-part series on mechanical ventilation. In this presentation, I'll review several ventilator modes and strategies. If you haven't seen part one, which covered background information on mechanical ventilation and lung mechanics, you can find the talk on my YouTube channel, Peter Sloan, MD. After watching part two, please feel free to continue to the final presentation on weaning and extubation strategies along with other topics, and then check out my other videos in critical care medicine at Peter Sloan MD on YouTube. So let's get started. Let's talk about what we mean by ventilator modes. A ventilator mode is a set of rules which control which type of ventilator breaths are delivered and how these are allowed in combination. Modes to be discussed today include spontaneous breathing trials with tube compensation and with pressure support, assist control with volume control, synchronized IMV with volume control, assist control with pressure control. Skip this. Before we get started, let's define what we mean by ventilator modes. A ventilator mode is a set of rules which controls which types of ventilator breaths are delivered and how these ventilator breaths are combined together. Today, I'll discuss several ventilator modes, and although this list looks long and daunting, there are actually even more than this. I'll actually define these as I go along. Let's start with spontaneous breathing trial. Spontaneous breathing allows the patient to breathe through the ventilator spontaneously with all of the ventilator monitors and alarms functioning. Because the patient's breathing on his own, he does not do any work of breathing. Levels of CPAP above 0 can be added to help oxygenation. Spontaneous breathing trials are appropriate for weaning trials and for patients who are intubated for airway protection needs only. Spontaneous breathing trial may be used with either low pressure support or what's called tube compensation on some ventilators to counteract work of breathing from the endotracheal tube or the tracheostomy tube. Here is a graph of spontaneous breathing trial which graphs the pressure over time. Patients breathing at a PEEP in this example of 5, and because they're breathing spontaneously, they draw a negative pressure with each breath. Their minute ventilation is strictly their own respiratory rate times their average tidal volume. They're truly breathing spontaneously right through the ventilator. Now we have the ability to add tube compensation to a spontaneous breathing trial. The tube compensation continuously adjusts the inspiratory pressure to compensate for worker breathing based on a combination of the instantaneous flow rate, the type of the tube, and the tube size. So for example, a high flow rate with an endotracheal tube, which is longer than a tracheostomy tube, that's a small dimension, would require a higher inspiratory pressure than a tracheostomy tube that's larger at a lower flow rate. So in this example, in this ventilator, we actually typed in the size of the tube and told the ventilator which type of tube was in there. And now during spontaneous breathing, as the patient draws flow through an 8mm ET tube, as the flow goes up, the actual pressure level that's compensating rises. So throughout the ventilator cycle, it's as if the patient's not breathing through a tube at all. The ventilator is doing the work through the tube, allowing the patient just to do the work of breathing on their own. Now, in this example, we have the tube compensation set at 100%, but you can compensate for less than 100% of the tube, although that's not done too often. So the tidal volume is determined by a combination of the patient's effort and the patient's lung mechanics. One other use of tube compensation is to account for accumulated secretions in the endotracheal tube that can form a biofilm and increase resistance, making it harder to breathe. In fact, biofilms have been documented to effectively decrease the size of endotracheal tubes by between 1 and 3 sizes. We frequently add pressure support to spontaneous breathing trial. We set a pressure, and then the volume that comes back when a patient breathes spontaneous with pressure support depends on the patient's effort, the mechanical properties of the lungs, which include lung compliance and lung resistance, and how much pressure support you actually set. The ventilator work is approximately proportionate to the level of pressure support. This isn't exact, but pretty close to say if you double the pressure support, you're probably approximately doubling the amount of work the ventilator is doing. There is a maximum pressure we can use, or what's called PS max, that's high enough that the patient does minimal effort. And on the contrary, there's a very low level of pressure support, usually between 2 and 6 centimeters of water, that compensates for tube resistance. In pressure support, we actually try to estimate the amount of pressure support you need to compensate for tube resistance to be compared with tube compensation where the machine calculates and adjusts the pressure support. But suffice it to say that pressure support in the 2 to 6 range compensates for tubes of varying sizes. Obviously, we use a little bit more pressure support for smaller tubes. So we can use pressure support as a weaning strategy. The strategy is simple. We start at a relatively high pressure support where the patient's doing minimal effort, and we slowly wean down to minimal pressure support to where we think that the patient's really only doing the work for themselves and that the ventilator is doing the work through the tube. So just a nomenclature issue, the pressure support level is the level above CPAP, which is the baseline pressure. So when we say someone's on CPAP of 5 and pressure support of 10, what we mean is the pressure support will raise the pressure up to 15. From 5 to 15 is a pressure support of 10. We also can add pressure support to some modes that allow spontaneous breaths. For example, you'll see in a few minutes that IMV mixes machine breaths with spontaneous breaths, so we can add pressure support, and we frequently add pressure support to IMV to compensate for the patient's work of breathing through the tube during their spontaneous breaths. Here's a very nice demonstration of work of breathing by McNeil in 2011 with a patient on spontaneous breathing with varying levels of pressure support. As you can see, as the pressure support goes from 0 to 10 to 20, the esophageal pressure starts at -10, showing a large effort with large negative intrathoracic pressure swing. As the pressure support went up, the negative intrathoracic pressure was ameliorated to a large degree, went only down to 0, and at higher pressure support, the pressure in the esophagus and the pleural cavity actually stayed positive, showing that you alleviated negative pressure swings with higher pressure support. This is a little hard to see, but I drew some vertical lines. In this first patient who's working hard, you can see some dyssynchrony and what's really abdominal paradox, where the abdomen is moving at a slightly different timing as the respiratory chest wall. As we raised pressure support, these two became simultaneous. So this first graph is really a visual representation of abdominal paradox. The final the final graph shows EMG output from the diaphragm, showing your diaphragm phrenic nerve is firing vigorously at no pressure support, less activity at medium pressure support, and pretty much gentle activity at high pressure support to show that the patient's not working as high. And in the final example, during this change of pressure support from 0 to 20, the patient's end tidal CO2, which reflects his blood PCO2, dropped from 47 towards 42. So in summary, we can see that incremental pressure support relieved negative esophageal pressure, abdominal paradox, diaphragmatic EMG output and helped improve elevated end tidal CO2. So this is the nomenclature for pressure support. The pressure support is the level of pressure above PEEP. I mentioned that before. And here there's less pressure support. It's only 5 above PEEP. The minute ventilation is still determined by the patient, how fast they breathe and how large their tidal volumes are. Pressure support does not determine tidal volumes. It only assists the patients with work of breathing on their own tidal volumes. So here's an actual ventilator with pressure support. I took this screenshot from a patient who was awake and cooperative. And what happened is they were breathing on their own. The flow pattern is strictly determined by the patient. The ventilator will give whatever flow it takes to maintain the pressure at a target. In this case, the target's 12 above 5, which is 17 is the target. So in this case, I asked the patient to take a longer breath in, and the patient did. He got a nice longer breath in, and it turns out the patient needed to supply higher flow for a longer amount of time to give the patient a larger tidal volume. Then I asked the patient to take a quick breath. Very cooperative patient. You could see the patient needed less flow for a shorter amount of time to get a shorter breath. You wonder what turns off this breath. Um, if you take a close look at one of these breaths, you could see the trigger of the breath is the effort of the patient lets the machine know they're starting. There's a little dip in the pressure. And the flow required by this patient went up to 40, but as they were taking less and less effort, the flow requirement went down. Otherwise, the pressure would have gone beyond the target. In this exact example, notice that when the flow is down to around 10, the breath terminated, and rather than having inward flow, it became outward flow. Well, let's see how did the ventilator know to terminate the breath right here. Well, 10 over 40 is 25%. In fact, that is one of the ways we terminate breaths is by setting the expiratory sensitivity at 25%. We also could set the flow trigger. In this case, 3 liters per minute is what the machine's sensing to initiate the breath. Now, the next mode I want to do is a true mode of full ventilator support that's called Assist Control Volume Control, or ACVC. This is our basic volume cycled ventilator, traditional ventilation, where we set the volume as an independent variable and the pressure that's required is dependent. It's a resting mode where all of the patient efforts are assisted by ventilator via delivery of a set volume at a set flow rate. It's triggered by the patient if the patient's respiratory rate is above the set rate, or it's triggered by a timer if the patient's respiratory rate falls below the set rate. We cannot wean a patient by lowering the set rate because the patient will keep triggering the ventilator at their own rate. The only real reason to lower the rate on assist control is if we think we're overventilating a patient. So here's my graphical representation of assist control. Every time the patient makes an effort and brings the pressure negative, it's recognized and the machine fires a volume cycled breath to a target tidal volume. So they get 3 of these in a row. However, if their own rate falls below the set rate, now notice 6 seconds went by. So that means the machine is set at a rate of 10, which is 1 breath every 6 seconds. Then it will revert to controlled ventilation, where the machine will deliver the same tidal volume in a similar fashion every 6 seconds at a rate of 10 per minute. So what you have here is identical breaths, sometimes triggered by the patient if he's breathing faster than 10 per minute, or delivered by the ventilator timer if the patient's breathing slower than 10 a minute. So we can see that if you divide the respiratory rate into the time, we get into 60, we get the actual amount of time. Obviously, a rate of 10 equates to 6 seconds. 60 divided by 10 is 6 seconds. And if the rate was 15, it would be 4 seconds per cycle. The minute ventilation is the greater of RR times VT that's set, meaning the patient breathes 20 and the tidal volume is 500, or the set rate and the set tidal volume. So if the set rate's 10, we know the patient will get 10 breaths a minute. So basically, they get the tidal volume at either their rate or the machine's rate, but they can't breathe any slower than the set rate. So here's an actual graph of the same mode I just went over, AC-VC. This is a traditional ventilator mode that's been around for at least 30, 35 years. So what happens here is we pick a tidal volume of 350 and we actually pick the flow pattern. We pick the peak flow at 40 liters a minute, and we pick the type of flow, which we pick in this setting, a ramp flow. The flow goes from 40 liters a minute down to 0 liters a minute. The actual flow pattern and the tidal volume do determine the amount of time it takes to get the tidal volume in. So after picking a rate, a tidal volume, the flow maximum, and the flow pattern, like I just showed you, the inspiratory time is determined by the actual flow of 40 liters a minute maximum means that the average flow in this example is 20 liters because it's going from 40 to 0. 20 liters a minute is 0.333 liters per second. I just divided by 60. So because the average flow is 333 cc's per second, which is 0.333 liters, it takes just over a second to get the 350 in. And you can see the width of this is about a second between 4 and 6. It's about half of the width of these blue lines. So another mode we use is synchronized IMV ventilation volume control. This is a traditional style of ventilation that's partial ventilatory support. It's used primarily to partially support patients with CO2 retention, COPD, or people that don't need full ventilatory support. But it's definitely not a good weaning mode. It was designed as a weaning mode, but in the late 1980s, several trials came out showing that IMV was an inferior, inefficient way to wean people from the ventilator. In synchronized IMV, the patient receives mandatory volume cycled breaths at a set rate, and in between these breaths, they're allowed to breathe spontaneously. In the assist control I showed you a couple of minutes ago, there were no spontaneous breaths allowed. You'll understand this better when I show you the graphs. Usually, the mandatory breaths are synchronized with the patient for better patient comfort. So here's my own graph of SIMV. The patient gets a breath on a schedule. In this case, every 6 seconds, they are getting a breath. In between the breaths, they can breathe on their own spontaneously. Now, in this one example here, the ventilator was able to synchronize this one breath with the patient's effort because it was about the time when they were going to get a breath. It's a little bit more comfortable for the patient, but these breaths are not synchronized. They're spontaneous because they're quite in between the timer for the machine breaths. So here's a synchronization to a patient effort. So the minute ventilation is a combination of the mandatory part of the ventilation is how many breaths you set times the tidal volume. And then the spontaneous part are how many patient breaths they take times the patient's own tidal volume. And the combined respiratory rate is the machine rate plus the patient's spontaneous rate. Much easier to understand this if I give you an example. So I'll do that right now. So if the combined rate's 18, patient plus machine, they're breathing 18 times a minute, and the machine is set IMV of 10 with a tidal volume of 700, and their own breaths when they breathe spontaneously are 500, we now know that the 10 machine breaths each give a mandatory 700 cc's. That's the setting. And the 8 patient breaths, we found out the patient's taking 500. They can take any size they want. These are not mandatory. So if we add up 7 liters from the machine, the red big green ones, and another 4 liters from these little guys, we wind up with a minute ventilation of 11 liters per minute. Now here's an actual graph on a ventilator of the same thing. You can see what's happening is the rate is set at 10. So every 6 seconds from here to here, there's a machine breath. In between the breaths, these red ones are spontaneous breaths. There's 4 of them. Now they look a little bit different from what I just showed you because I mentioned in pressure support that pressure support can support the spontaneous breaths in IMV. So for example, the pressure support is set at 5, the PEEP is 7.5. So when the patient breathes on their own, they get pressure support up to around 13 or so. The mandatory breaths are just like assist control. We pick the flow pattern. We pick the maximum flow at 80 is what we picked on this patient, and we picked a ramp flow curve, which is right over here. We'll get to this later, but you can see the patient's not doing very well. They're having a very large negative pull in the middle, and we're going to talk about this later. It's an interesting topic of dysynchrony. It's one of the reasons we're using more modern modes beyond plain volume control. Volume and flow control can create problems with patient synchrony, and you'll see more of these dysynchronous curves. This is not what we expect to happen if the patient's comfortable. So in summary, in SIMV-VC mode, we set a rate, we set the tidal volume, here it's 600, maximum flow, here it's 80, flow pattern, we usually pick a ramp, it's much more natural than a square wave. Additional breaths are allowed, but are all spontaneous. Spontaneous breaths may be supported with pressure support like they are here at 5, or we can even use tube compensation, which I talked about earlier. Now I want to change the topic to pressure cycle ventilation. Pressure cycle ventilation is a style of ventilation where the common denominator, which is the common denominator of several modes. Modes that we can talk about are bilevel, APRV, IMV-PC, ACPC, and IRV. But in a pressure cycled strategy, we set the PEEP low and we pick either the inspiratory pressure or the PEEP high as a mandatory strategy. If we pick the inspiratory pressure, we're also picking the PEEP high because the PEEP high is the PEEP low plus the PEEP inspiratory pressure. And if we're on one of the modes where we pick the PEEP low and pick the PEEP high, the inspiratory pressure is also determined by the difference. If we were to pick PEEP low at 10, PEEP high at 25, the inspiratory pressure would simply be 15. On top of picking the pressures explicitly, we also pick the ventilator rate and we choose one of the following 3 parameters: inspiratory time, expiratory time, or IDE ratio. So once we have a rate, if we were to pick the inspiratory time, we would actually already have determined expiratory time and determined the IDE ratio. For example, if we pick a rate of 20, which is 3 seconds per cycle, and we pick an inspiratory time of 1, then mathematically we would have unknowingly picked an expiratory time of 2 seconds and an IDE ratio of 1 to 2. Well, when we pick a pressure differential, P inspiration, when we select that, we really don't have any idea what the volume is going to be coming back to the ventilator. We really have to run up to the ventilator and see what's coming back to the ventilator. Well, what returns to the ventilator depends to a large degree on the inspiratory pressure. The higher the inspiratory pressure, the larger the volume will be, but also is determined by compliance, by airway resistance, and not mentioned here by patient effort can influence the volume. Just like I said with pressure support, the ventilator work is approximately proportionate to the amount of inspiratory pressure. Not exact, but it's a good approximation. So what is inverse ratio ventilation is when we set the I to E in an inverse where we have more time in inspiration than in expiration. Typically, we keep expiratory time under 1 second, and we use this to generate auto-PEEP and to raise mean airway pressure to help oxygenation and prevent expiratory collapse of alveoli. So that's how we define inverse ratio ventilation. We can run a pressure cycle mode with or without inverse ratio ventilation. This is just how we set up the timing. Effectively, as soon as we invert the IDE ratio, for example, 3 to 1, we call that inverse ratio ventilation. So I haven't gone over any modes here. I just showed you the themes that will come up with all pressure cycled ventilation. These are the themes. So here's a graph that I drew for you guys of the pressure ventilation with um, AC-PC mode with inverse ratio versus conventional. So let me just go over that. Here is an AC-PC. We're on a regular rate, we're doing a pressure control. We're picking a high pressure and a low pressure. We're also picking the timing, in this case about 3 to 1, which means we're in an inverse ratio ventilation. Now in this example, the peak pressure is 30 and the PEEP is 10. In the lower example, conventional ventilation, the PEEP is 10, the peak airway pressure is 30, but we're flowing it in with a flow cycle and the pressure goes up and down. Now in this example, the mean airway pressure is very low at 15 in conventional ventilation. It's closer to 10 than 30. As you can imagine, same pressures 10 and 30, but we're spending much more time at 30 and we're staying at 30 for the entire inspiration. It's a square wave. So we can build up a higher mean airway pressure of 25, even though the peak and the base pressure is the same at 30 and 10. So notice how just changing the timing and the shape of these curves gets our mean airway pressure up from 15 to 25. Pretty good trick. This is a very useful strategy for someone with ARDS or difficulty with oxygenation. So let's talk about PEEP while we're on the topic of increasing ventilation. I want to distinguish extrinsically applied PEEP to intrinsic PEEP. Extrinsically applied PEEP is pressure applied externally to the proximal airway, and it's present throughout the respiratory cycle. We apply this from the ventilator at the endotracheal tube location, the tip of the tube where the ventilator attaches. Intrinsic PEEP is defined as additional pressure remaining in the alveoli at end expiration above and beyond extrinsic PEEP. So to develop intrinsic pressure in your alveoli at end expiration, you must have active end expiratory flow. In your alveoli, the total PEEP is a combination of extrinsic PEEP plus the built-up intrinsic PEEP. I'll show you some graphs of this. Elevated PEEP total is all that the lungs see. At the level of the alveoli, they simply only see the PEEP total. In fact, the alveoli really don't care if the PEEP was extrinsically applied or intrinsically applied. Total PEEP is all the alveoli care about. Elevated PEEP can be transmitted, total PEEP can be transmitted to the heart, suppress transmural LV filling pressure, decrease cardiac output, decrease blood pressure, and contribute to a shock state. Now, another thing to know about Auto-PEEP is Auto-PEEP raises the work of breathing to trigger a ventilator breath if we use a pressure trigger. So before I showed you if your PEEP was 5 and your pressure required a -3, you would have to pull 3 pressure in to trigger the ventilator. If your Auto-PEEP was like 6, instead of pulling in 3, you'd have to pull in 9. So the patient must generate enough pressure to overcome the trigger sensitivity that was set, and in addition, extra pressure to overcome the Auto-PEEP. So that can also cause dyssynchrony and really ineffective firing of the ventilator at times. So we have patients can sometimes do very poorly if they're trying to trigger the ventilator when they have a lot of Auto-PEEP. They can be dyspneic and asynchronous. So here's an Auto-PEEP maneuver. Let me show you what's going on. We have a pressure-controlled ventilator style. It's a little bit inverse. And we wonder, is there really enough time to finish exhaling? And the answer is no, there's not. At the end of exhalation, there's still flow coming out. Think about what's going on at end expiration. whatever the pressure is at the mouth, let's say that that's 5, we can tell there must be higher pressure in the alveoli driving the pressure out of the lungs. It would be impossible to have flow without a higher pressure in the alveoli. So already right over here, I can tell for sure that there is intrinsic PEEP or auto-PEEP in the alveoli. I just can't tell how much there is. I know there's significant amount because the flow isn't even close to zero. It's quite a ways off of zero. So to measure the auto-PEEP, to measure the intrinsic PEEP, we do something called an auto-PEEP maneuver, which is also called an end expiratory hold. So watch right over here what we do. Hold the breath at end expiration, and we allow the pressure in the alveoli to equilibrate with the proximal pressure. And then on the ventilator, we're able to actually see the system pressure, which is the equilibrated alveolar pressure throughout the system. And the reason the pressure equilibrates is in the absence of flow, all of the pressure equalizes. I talked about that in my first talk, but the pressure at both ends of a system are exactly the same when there's no flow. So the mouth and the alveolar pressure is exactly the same when there's no flow. Well, that means that the amount of intrinsic PEEP was approximately the same as the amount of extrinsic PEEP, but we couldn't have recognized this easily from the ventilator screen. We could tell it's there because of the presence of expiratory flow at end expiration, but we didn't know how much there was until we measured this. So I wanted to remind, if you didn't see my first talk, that when there's no flow, the pressure is equilibrated. P and P are the same level at both ends of the no flow. We just talked about that. This extra intrinsic PEEP adds to PEEP to cause the total PEEP. So this isn't just theoretical. We do these on the ventilator all the time. Here's a patient who has expiratory flow still present at end expiration. And although the PEEP is 5, we suspected there was auto-PEEP. So we put an end expiratory freeze or hold, an auto-PEEP maneuver on. And during the auto-PEEP, we allowed the alveolar pressure to equilibrate with the proximal airway pressure. And we can see that the total pressure is 17, just under 20. The PEEP was 5, and even the ventilator calculated that the intrinsic PEEP was 12, making the total PEEP 17. So most ventilators can do an auto-PEEP maneuver. They have to be done at a time when the patient is relaxed and synchronous with the ventilator. If the patient makes an effort during the auto-PEEP maneuver, it cuts off the maneuver. Here's a patient on AC-PC mode. What AC-PC mode is we actually control the rate at a minimum, in this case 21 breaths a minute, and we pick the inspiratory pressure and the PEEP. So the PEEP is 5, the inspiratory driving pressure is 30, meaning the peak pressure is 35. So we picked yellow to be 5, delta P to be 30, which forces the peak airway pressure to be 35 as measured by the ventilator. So we know this is doing what we wanted. We also, on top of picking the minimum rate of 21, we pick an inspiratory time of 0.9 seconds. Now a rate of 21 is about 3 seconds per breath. Just divided 21 into 60, I got about 3 seconds. Because inspiratory time is 0.9 seconds, expiratory time must be a little bit more than 2 seconds. And you can see that's a little bit more than 2 seconds. So in assist control, pressure control, 100% of the breaths are pressure control breaths that are instituted either by a timer or by patient's effort. We set the minimum rate and the pressure, as I mentioned, and we pick inspiratory time or expiratory time or IDE. In this case, we picked inspiratory time of 0.9 to give us an expiratory time of 2.1, but had we chosen an expiratory time of 2.1, we would have had an inspiratory time of around 0.9, and we could have also picked a 1 to 2 ratio, which would have frozen both of these. Once we pick the square wave pattern, there's Assist control means the patient can breathe faster. So if they start to breathe faster than 21, the machine will follow the patient's lead and give them, let's say, 25 breaths a minute. Now that shortens the cycle time. Let's say they were breathing 30 times a minute. They would only have 2 seconds per breath in and out. Well, we freeze the inspiratory time because that's the one that was set at about a second, and that leaves only 1 second for expiration. So what the machine does is it freezes the one we select and adjusts the other one to the shorter, so that it can account for the shorter cycle time. So here's another mix and match mode. It's SIMV-PC. What this is, it's an IMV style where they intermittently are forced to get a machine breath. But unlike SIMV-VC, where we pick the volume, in SIMV-PC, we actually don't pick a volume. We pick an inspiratory pressure and how long it goes in for, and we have to see what comes back to the ventilator. In this case, 517 came back on that breath, but that's not a setting, that's what returned. Now, in all IMV modes, between the mandatory breaths, the patient's allowed to breathe on their own, and in all IMV modes, spontaneous breaths may be supported with pressure support, in this case 8. So let me review this one more time, it's a little confusing. We set a mandatory rate, in this case 12. We set the inspiratory pressure, in this case 15 above PEEP, which means it's going to go up to 20. We set the time, in this case we set an inspiratory time of 1 second. Because the rate's 5, we're leaving 4 seconds for expiration. That's from this green to that green. During expiration, because it's IMV, the patient's breathing spontaneously, and in this case, the spontaneous breaths from a PEEP of 5 are supported with a pressure of 8. So when they breathe a red spontaneous, it goes from 5 to 13, which is what was picked up on the machine. Spontaneous breath hit 13. If this had said a mandatory breath, it would have hit, what is it? It would have hit 20, 5 plus 15. So if you're lost at this point, I would stop the video because it gets a little bit more involved and confusing. But let's just review. We talked about volume versus pressure cycle breaths. We talked about the two main volume modes are assist control and IMV volume control for each. And we just talked about two main pressure control modes, ACPC and IMV-PC, where patients, when they get the mandatory breaths, it's pressure regulated, not volume regulated. They have some interesting models of ventilation. And again, I really want to encourage you to take a break and stop the video right now. If you haven't followed most everything I said, you will get confused. But if you're with ventilators, you might want to stop the video now, try to review all of these modes up until now on rounds, and then come back to this video at this point, or if you ever see some of these fancier modes. But I want to talk to you about some of the modes that are very helpful. We've been switching to these more modern modes, mostly for patient synchrony and comfort. So this is an interesting mode called pressure regulated volume control. We set a target tidal volume and a respiratory rate, and we pick an inspiratory time. But what we don't pick is we don't pick a pressure. Mandatory breaths are pressure-controlled breaths which are instituted by a timer, and over time the ventilator adjusts the pressure control level to achieve the tidal volume. And the way it does is it keeps a rolling average of the last several return tidal volumes. So if the tidal volumes start to fall off for whatever reason, the machine will boost up the pressure to get the tidal volumes back to target, and vice versa. Now, if the patient breathes faster than the set rate, then the patient will trigger the breaths more often. The machine will keep frozen whichever timing parameter is set and steal from the other parameters. So in this example, the rate looks like it's around 20 because it's every 3 seconds. We have 3 seconds, and the timer we picked 1.2 seconds in with a total of 3 seconds. So that leaves 1.8 seconds out. If the patient started to breathe at 30, we would only have 2 seconds. The machine would continue to inhale or inspire for 1.2 seconds, so expiratory time would be cut to 0.8. Now, what's the beauty of this is the patient's going to get the tidal volume that was asked for, but the machine's going to allow any flow pattern. And I don't know if you remembered, but when I showed you the SIMV-AC before, I showed you a nasty curve that was sucking wind deep in. But here, the patient gets whatever flow is required. So I'll show you. Why this is all very interesting. There's no chance the patient will get insufficient flow, which is a reason for dyssynchrony. I'll show you some of that. But I'm also going to show you what happens if the resistance changes, what will happen to the ventilator. So this is a patient that I did with the residents at the bedside that had been on this mode, PRVC. Tidal volumes were coming back at 600. Patient was asleep, very comfortable, synchronous, everything was good. And then several breaths before I captured the screen. Let's go back about 1, 2, 3, right around over here. 3 breaths back. I can't really reach off the screen, but before I did the screen capture and froze the screen, I pinched the endotracheal tube enough to make the tidal volumes fall off. Remember, the machine's delivering a pressure, so if I squeeze the tube and the machine delivers the same pressure, the tidal volume will fall off. Now, by the time the machine got to this pressure, the tidal volumes had fallen off to around 300. This happened before the screen capture. I really need a video to show you this. But the machine realized right here the tidal volumes were falling short, so I drew a red line at the current peak airway pressure. At that time, I think it was around 20. What happened is the machine realized the tidal volumes fell off and it started to incrementally rise up the pressure target until it got the tidal volumes up to 600. And then if I had left it pinched, it simply would have gotten back to 600 cc's and a higher pressure. But for dramatic effect, I did one more thing, is right before the screen capture, I released the endotracheal tube and I freed up the resistance. So what happened then is I had this very high pressure suddenly pushing in against a normal resistance. Right then, I took the screen capture at that moment and 1,000 cc's came back because we were at the other extreme. We had built up a high pressure to overcome very high resistance. So the theory here is as your lung mechanics change, the pressure target changes to keep the tidal volume at a set tidal volume. In this case, first the lung mechanics got bad when I squeezed the tube, and then the pressure rose up. And then when the mechanics got better, when I released the tube, the tidal volume was too large. So what you can't see after the screenshot is the pressure inched its way back down to where it started. So it can adjust upward or downward. Pressure rises up over time as the lung mechanics get worse. Or I mentioned biofilm. If biofilm starts to build up on the inside of the endotracheal tube, the pressure will inch up. But what we really like about PRVC is that the patient determines their own flow pattern. This isn't exactly a ramp pattern. It stays high longer, and I'll show you why that's so important. I already described what I did here. Oh, before I describe dyssynchrony, I just wanted to show you, I just actually showed you about 6 modes, and I just want to show you the schema. It's much simpler than it seems from how complicated it just looked. It did seem quite complex. We really have 3 types of breath. Volume control breath is when we simply pick a volume, push in 600 cc's. VC plus, which is also called PRVC, is we pick a volume, but we allow the machine to adjust the pressure until it achieves the volume. That's what I just showed you with the PRVC. PRVC and VC plus are 2 names for the same setting. It just depends on the ventilator brand. Another way we do the ventilator breaths are pressure controlled breaths, where we simply pick the low and the high pressure and how long it stays at high and low. We pick low, we pick high. So here are 3 different modes lined up. Now, in This example, all of these modes have IMV style where intermittently we do a machine breath. In between it's spontaneous. With volume control, IMV with volume control, we did a volume controlled breath with 2 spontaneous allowed. In VC plus, we did the machine breath, and then in pressure control, we did the pressure breath. With assist control, what happens with AC is you can get the same exact types of breaths mixed in, but they never get spontaneous breaths. So in this case, every time the patient breathes, they in AC with VC, they get a volume controlled breath. With AC VC plus, they get a pressure release controlled breath. And with pressure control, every time they breathe or make an effort, they get a pressure controlled breath. Notice in the AC mode, there are no spontaneous breaths allowed. And in the IMV, so it's really 2 dimensions. That's why all of our modes have pairs. You say, what's the style of ventilation, intermittent or mandatory? And what types of breaths, volume controlled, pressure release volume control plus breaths, or pure pressure controlled breaths. So with 2 modes and 3 breath types, with 2 styles of ventilation and 3 breath types, we can mix and match and get 6 modes. It gets a little bit confusing. Now I'm going to stop again because as I'm talking, I realize this is complicated. So if you're new to this, you've seen plenty. If you're back a 3rd time, or you're a fellow in pulmonary, or you're a respiratory therapist, you're welcome to stay with me, but I really don't mean to go all the way and leave people in the dust. So if you've become confused, you need to just stop the video and go back to work, see some patients, and try to see if this all sinks in, and you can come back another time. Here's another mode of ventilation, APRV. Um, some ventilators, it's called APRV. Another brand of ventilators, the Puritan Bennett, they don't have the trademark on APRV. They call it bilevel. They're not exactly the same. APRV implies you're going to keep expiratory time quite short. Bilevel can be used with short expiratory times. It also can be used with longer expiratory times. So it's a little bit confusing, but the idea here for these types of modes is we allow someone to breathe spontaneously at a high pressure and alternate spontaneous breathing at a low pressure. Now, if the low pressure is kept for a very short amount of time, typically the patients won't take a breath. But for demonstration purposes, I have the patient breathing spontaneously at the high volume, and I have him breathing spontaneously at a low volume. And the pressure oscillates between high and low at a set frequency, which is called the set rate. In this example, we see there are 2 types of breaths that come back to the ventilator. The patient's breaths, which tend to be smaller volumes, and the mandatory breaths, which is dropping off from high pressure to low pressure, lets out a large volume. So PEEP low is where we're starting. PEEP high is really PEEP low plus the inspiratory pressure. In our Puritan Bennett ventilator, when we do bilevel, we actually set PEEP high and we set PEEP low. The ventilator actually calculates the difference, or you can calculate the difference as the inspiratory pressure, but inspiratory pressure is not a setting, it's implied. The spontaneous breaths I marked in red, and the release breaths, it's releasing from high to low, lets out the volume, is marked in green. You can see in this case, the green release breath is the larger, at least twice as large as the spontaneous breaths. Another type of ventilation I'll briefly touch on is proportional assist ventilation. It's spontaneous. It's a spontaneous breathing mode we can consider as an alternate to pressure support. It has some theoretical advantages. The pressure setting adjusts automatically to patient demand, and the machine does a set proportion of the worker breathing based on patient demand, resistance, and compliance. So we use proportional assist ventilation in spontaneously breathing patients with intact respiratory drive and intact neuromuscular function. If they don't have an intact respiratory drive, they have no mandatory volume, And if they don't have neuromuscular function, they might not even trigger the ventilator. So what we like about this is there's increased comfort and less asynchrony. And we don't set either volume or pressure. It's truly a spontaneous mode. The ventilator is just proportionately assisting the patient's effort. So we do set the proportion of the work or breathing we're supporting, which makes this an interesting mode. So I'll show you some screenshots. Here we're setting the patient to get proportionate 50% of work of breathing. The timer and the inspiratory pressure is not set. This is confusing. This is for manual inspiration only. 1 second breath. So the patient, the only real thing we set is the PEEP and what percentage of support. So what's going to happen is in proportional, the patient decides when they want to breathe, how large they want to breathe, how long they want to breathe, and who does the extra work as demand goes up is the ventilator. So if the patient's doing 50% of the work and then the work of breathing goes up because of secretions, the ventilator will do extra work. Now in pressure support, if the patient's doing 50% of the work of breathing and then the demand goes up, the patient will then do 80% of the work of breathing. There's no way for pressure support to do extra work just because the work of breathing went up. So let me show you what the machine does. The machine, knowing the pressure support, knowing the lung compliance and resistance, which it can calculate, it actually determines what the work of breathing total is theoretically. And in this case, the ventilator is set to 50%. So it does the work of breathing. It knows that a value over 0.7 joules per second is usually excessive. So this patient's probably working fairly hard. So if you see someone struggling, especially if they're struggling and their work of breathing is outside of this comfortable zone, we could raise the pressure, the proportional assist pressure to 60%. That would scooch this work of breathing down towards the left because the machine would be doing more breathing. So what's the difference between this and pressure support? One is we get a lot of very nice feedback regarding where the patient is with respect to work of breathing and how high the machine thinks the work of breathing is, because we never know that. But another way to think of it is if you're on pressure support comfortable and the work of breathing goes up, the pressure support itself does not go up. If you have PSV set at 10 and the work of breathing goes up from secretions, pressure support doesn't automatically change. So what happens is the patient's effort increases. In proportional assist ventilation, when the work of breathing goes up, not only will the patient's effort increase, but the machine will also do more work of breathing, sharing the extra work with the patient. So it sort of tracks along as work of breathing changes to make sure the patient always stays at approximately 50% work of breathing support. I frequently get asked which modes to choose, and I'll go through this briefly. We have a lot of choices of modes. So for airway protection, we use spontaneous breathing trials, tube compensation. Sometimes we use pressure support with the spontaneous trial just to make sure the patient's not struggling through the tube. We use partial ventilatory support for patients that are either don't need complete rest or COPD patients where if you give them complete ventilatory rest, it might correct their chronic hypercapnia back to normal. One of the modes is IMV. Of course, this can be IMV volume control or IMV pressure control or even IMV PRVC. We choose full ventilatory support for patients with severe respiratory failure or severe critical illness. Full levels of support do not allow any spontaneous breathing. Assist control, whether it's ACVC or ACPC, CMV, which is mandatory ventilation, PRVC, which was that VC plus I showed you. These are all examples of full respiratory support. I think I repeated myself there. Impending respiratory failure. If someone is not intubated and they have impending respiratory failure, we usually try a non-invasive form of ventilation, either NIPP ventilator or high flow, which is not actually a form of ventilation, but it does do indirectly, does help with worker breathing. For weaning, we choose spontaneous breathing trial as our go-to method. We could either use a low pressure support or tube compensation to compensate for endotracheal tube. If we wean, we can also wean with pressure support going from maximum to minimum, and we can wean with bilevel by dropping the high pressure and stretching out the interval, or we can wean with proportional assist ventilation by dropping the proportion of support. That was one of the ventilator modes I showed you just a few minutes ago. So we have all of these methods of weaning. In the 1980s and 90s, we used IMV as a weaning mode. I mentioned that in my first talk, but that's fallen out of favor because some international studies out of France in the late 1980s showed that it was an inefficient way to wean. If we see somebody that's dysynchronous and uncomfortable in the ventilator, but we're trying to let them be awake and not want to heavily sedate them, we have some modern modes that help with synchrony and comfort. These are PRVC on the Puritan Bennett, but also on other ventilator modes. They're called VC plus, or actually on the Puritan Bennett, they're called VC plus. Um, on the Draeger, it's called CMV with autoflow. Another brand calls it PRVC. But these are the modes that allows us to choose a target tidal volume, but we don't choose the flow pattern, and the ventilator will adjust the pressure to deliver the target value. In my next talk, if you can handle more details, I'll actually show you how these modes take care of dysynchrony, make the patient more comfortable. So that brings us to the end of part two. I know that was complicated. Thank you for sticking to the end. Part three gets a little bit easier. The only tricky topic is asynchrony. Then we're back to basics, weaning strategies and non-invasive ventilation. So I encourage you to move on to part three. If you ever get any trouble finding my videos, just put Peter Sloan MD into the YouTube search box. You'll get right to my homepage. Thanks for watching this video. Hope you enjoyed.